Thank you very much. My name is Keith Gaynor. I'm a clinical psychologist and I work in the outpatient department of St. John of God's. And we're going to talk this evening about post-traumatic stress disorder and depression. And the title I was asked to speak to was the idea of the shattered mirror. That post-traumatic stress has a lot to do with memory and the memories we have of traumatic events. And that sometimes those memories aren't these perfect pictures that we get back, but they're shards and broken and little aspects of the thing that happened to us. Michael Fassbender, the Irish actor, is in a current movie about Macbeth, the Shakespeare play. And he put forward the idea that Macbeth may have been suffering from PTSD. That Macbeth was a warrior. He spent his whole life in battle. He comes and he murders King Duncan. And that from that point, he becomes tortured by nightmares and horrors from the things that he's seen and the things that he's done. And so the idea that PTSD is a new thing, it may date all the way back into our history. But we only started really paying attention to it in World War I. And that's when a large group of people, many thousands of soldiers, started to experience shell shock. And they started to come home and they started to be unable to do the things that they had done previously, unable to fight and live and work and all the things that they wanted to be able to do. Now, at that time, they were treated appallingly. It was blamed on them. It was seen as cowardice. It was seen as weakness. It was seen as their fault. People were court-martialed. People were excluded and ostracized. But a lot of the feelings that they had may be very relevant to how we continue to think about and talk about PTSD. They felt like failures. They felt that they were weak inside. And they felt that somehow it was only them. It was only them that this thing had happened to. And when we think how the British Army and the other army leaders treated them, treated them so appallingly and so excluded them, it's very easy from the depths of, from history to look back and go, well, that's appalling. But when we think of current employers, we could ask, how easy is it to be a guard or a nurse or a firefighter or a first responder or a paramedic in today's climate with today's employers? And how open are they to seeing that when we put people in dangerous situations and put people in harm's way, that sometimes they're not going to come out of it as well as when they went into it? And that's not the individual's fault. That's about the situation that we put people into. And so, although we're able to look back at World War I wonder if we've really learned the lessons from it. This is a poem, it's just cut off at the end, by Wilfred Owen, that lots of you will know from your junior certs. And it's about the experiences that the soldiers had. But it's very specific and it's very interesting when you read it in the light of PTSD, when you start thinking of it in terms of post-traumatic stress. Gasp, gasp, quick boys, an ecstasy of fumbling, fitting the clumsy helmets just in time. But someone still was yelling out and stumbling and floundering like a man in fire or lime. Dim through the misty panes and thick green light, as under a green sea I saw him drowning. In all my dreams before my helpless sight, he plunges at me guttering, choking, drowning. If in some smothering dreams you too could pace behind the wagon that we flung him in, and watch the white eyes writhing in his hanging face like a devil sick of sin. If you could hear at every jolt the blood come gargling from the froth-corrupted lungs, obscene as cancer, bitter as the cud, of vile incurable sores on innocent tongues. My friend, you would not tell with such high zest to children ardent for some desperate glory. The old lie, dulce et decorum est, pro patrio mori. And when we look at it, this all takes place in a dream. What he's talking about is the dreams he has after this experience of seeing the other soldiers suffer. So in all my dreams before my helpless sight. And what he's talking about is his re-experiencing of what happened to him during the war. And notice what else is there. It's all about the senses. My helpless sight. If you too could pace, if you could watch, if you could hear. He's experiencing it in all his senses. And notice also the repetition. drowning, drowning, face, face, sin, sin. And that this is happening over and over for him in all his dreams. It's not a single dream. In all his dreams, this thing happens to him. This image comes back to him. And so, although he doesn't talk about it and he doesn't name it, what he's experiencing is a lot of what we're going to be talking about throughout the rest of this talk. PTSD really only came into consciousness in terms of psychiatry and into the world in general following the Vietnam War. In that all these American troops went off to war, these huge, strong, powerful, fit men, the pride of the American youth, and they came back and they weren't able to be part of society. They really struggled to fit back in. They were able to be in the jungle, but they weren't able to hold down a job. They overdrank. They became depressed. They became massively anxious. They had dreams. They had flashbacks. There was a high rate of suicide. There was a high rate of alcoholism. And so they started to realize that the men they were sending over to Vietnam weren't coming back well. And it's only at that stage that psychiatrists started to label PTSD properly and call it post-traumatic stress disorder. And it came into the first diagnostic manual at that stage. It's only then that money started to go into research and into treatments. And that was mostly through the veteran associations in America. And they started to recognize the effect that putting people in traumatic situations has on them. That if you put somebody in danger, if someone's life is put in danger, if something awful happens to them, it's not easy to brush off. It's not easy to walk away from that. In fact, those scars can stay with us and those memories can stay with us for a very long time. Long after we're back and home and safe and working in a restaurant in Arkansas, we're still thinking about being in the jungle and still thinking of the noises and the things we experienced there. So this means, so if you're thinking about the 100 years or so it took to really, for PTSD to begin to really to be thought about, it means it's changed its definition and focus a lot over time. It started with soldiers, and then people started to think about also police and paramedics and first responders. And now it's become, with DSM-5, a much broader range of experiences. So the definition started with having to have a life-threatening event. That you couldn't have PTSD unless something life-threatening had happened to you. And that's changed. And now it's either experiencing a life-threatening event, or witnessing a life-threatening event, or learning about a threat to a close family member, to a child or a loved one, or repeated exposure to traumatic material. And this is where it's most interesting for a lot of people who are working in frontline services in Ireland. So if you're a policeman, and in investigations, you're coming across car crash victims every day. Your life isn't threatened. There's no danger to you, but you're coming across highly traumatic experiences all the time. If you are an ICU nurse and you're coming across death and dying all the time, and you're coming across traumatic sites, that can and may affect you. And it's this repeated exposure that, in fact, may affect the most amount of people. But it's also something that happens when we experience a threat to our life or a threat to our well-being, or when we witness it. We see a threat to somebody else. So what is post-traumatic stress disorder? The core of PTSD is an ongoing feeling of threat. So someone has experienced something in the past, something awful has happened, and their body and their mind expects this to happen again. And they expect it to happen again at any moment. They expect it to happen today, tomorrow, at any time in the future. So this feeling of threat hasn't gone away when the threat went away. The assailant is gone, or the car crash is over, or the war is over. But the sense of threat remains. It hasn't left. It's repeating. We continue to feel that, as if it was happening again right now. The core symptoms of PTSD are re-experiencing symptoms, so flashbacks or nightmares or just intrusive memories. We know they're a memory, but they're jutting into our consciousness. We can't control, we can't bring them in or not bring them in. They come in and they dominate our experience. Avoidance symptoms, where we try to avoid thinking about it or avoid triggers. So if we these things get set off in crowds, we avoid crowds. If they get set off at night, we avoid darkness. If it gets set off by traffic, we avoid traffic. Whatever. Emotional numbness, so where we feel considerably less. And a reduced lifestyle, so we don't go to work, or we don't see friends, or we don't go and do our normal everyday things. And then persistent anxiety. So we have this sense of hyperarousal, increased adrenaline, all the time or a lot of the time. And that leads to sleep problems, it leads to concentration problems, and it leads to a sense of hypervigilance, which just means watchfulness. That if I had PTSD, I would be in this room scanning to see where's the danger? Where's the danger going to come from? And it's bad enough giving a talk, but if I also had PTSD, I'd be watching out for where the physical threat would be coming from up there, or from up there, or from up there. And that constant sense of being alert and being on guard and constantly being anxious. And so there's a couple of interesting things about this. You would think that this, we'd be seeing a lot of it. But in fact, people don't come forward. So after the London bombings, most people probably remember the 7/7 bombings in London. They set up a special PTSD treatment service because they expected a lot of people to come forward. And they got a lot of money, and the government rushed in, and it was a big high-profile event. So there was no shortage of therapists, there was no shortage of treatment, the funding was all there, and the people didn't come. And one of the interesting things is they expected people to come just through the normal route, through GPs and everything. And in fact, only 15% of people came through their GPs. The service actually had to go out into A&Es, into alcohol programs, into GP services, and talk about what PTSD was before people recognised that they had been in, this is what had been causing their problems. And that often PTSD and trauma becomes subsumed into alcoholism or addiction or depression. People feel anxious and they use drink to make it go away, or they use cannabis to make it go away, or they don't leave the house so that they don't feel these symptoms, and then by not leaving the house, they become depressed, or they can't go back to work and they become depressed because of it. And that becomes the thing ultimately they become referred for. They become referred for the alcoholism or the depression, but the underlying difficulty is the PTSD. And it's only later that you find out, when you go through a whole history, that this has been the original cause. Okay. I'm going to take a breath of water. That's all right. So, why does our body and mind do this thing? Why don't it let us just get on with it and get past it and move on? Everyone says, let go, move on. Why doesn't our body and our mind allow us to do it? Well, one of the things to understand is that PTSD is an anxiety disorder. It's in with all the other anxiety disorders, like panic or social phobia or OCD. It's an anxiety disorder. Its primary difficulty is anxiety. Now, there's lots of other emotions. There's guilt and anger and shame, and they're very important too. But the primary issue is anxiety. And anxiety, as most people know, is an evolutionary response. That we get a burst of adrenaline in order to keep ourselves safe. Okay, we'll do it in a different order. So, what does evolution do? What's the primary purpose of evolution? I would like everyone to hold their breath, please. I'm going to take a deep breath and hold it. And I'd like you to keep holding it until you die. And the thing is, you can't do it. Your body won't let you do it. No matter how much your mind wants to do it, no matter what you're telling yourself, your body won't let you do that. And in fact, your body won't let you die in lots of other ways as well. It keeps you safe. It makes you faint if it thinks you're bleeding. It does all sorts of things to keep you alive. Your body is evolutionarily programmed to override your brain and to keep you from doing stuff. And so the number one thing your body will do is keep itself alive. Now, in a trauma, you've already been in a situation where your body has almost not been alive. It's been in a very dangerous situation for whatever reason. And your body has learned, I'm not going to be in that situation again. So the last time you put me in a car, the car crashed, I'm not going in another car. The last time we went out at night, someone tried to shoot me, I'm not going out at night. The last time we got on a plane, the plane almost crashed, we're not getting on any other plane. That the body brings out this anxiety response so that we stop putting it in danger. Now, the body mightn't always get that right. So the body may misinterpret it. It can't tell the difference when darkness is safe and when darkness is not safe. It can't tell the difference between a car moving at 100 miles an hour and a car moving at 10 miles an hour. It has to be taught. But that gut response, that initial response, that adrenaline response is there to keep us safe. And so the huge anxiety response that happens in PTSD is deeply useful, it's deeply functional, and it's entirely normal. And what we have to do is to train our body back into what's safe and what's not safe. And so we have to teach it that, yeah, it is okay to go out at 7 o'clock at night even though it's dark. But no, it's maybe not okay to go down that dark alley where it does look dangerous. It is okay to get back on this plane because I want to fly and I want to have holidays. But it is, other things I'm not going to do. I'm not going to drive at 100 miles an hour, but I am going to drive at 50 miles an hour. And we have to train our body back to doing that because it won't know until we train it. And so that's why there is an initial anxiety response. We then have to ask ourselves, why won't that anxiety response go away? I'm now safe. This thing hasn't happened again. I haven't been shot at, or I haven't been stabbed, or I haven't been in a fire, or I haven't been in another car crash. So why isn't the anxiety going away? And there's two things. We keep re-triggering it, and we haven't retrained it properly. And our memory. That our traumatic memory is often jagged and broken and not clear. And so it keeps reoccurring. And it reoccurs through the flashbacks and the nightmares and the intrusive memories. And so that we really struggle then to get past it because it keeps reoccurring to us through our own memories. What I want to talk briefly is what's recommended in terms of treatment. And then we're going to talk through exactly how this works. And then an example. We're just going to use a generic car crash as an example of what we would do and how we could work with it. All right? Today, I'm a psychologist, so I'm not going to talk about medication at all. It's an area I don't know anything about, and it'll be well outside my area of expertise. What I'm going to talk about is psychological interventions for PTSD and PTSD and depression. And in particular, what we're going to draw this from is, sadly, you can't see, which is in the bottom right-hand corner, which says psychological interventions, and then says the NICE guidelines. And it's the National Institute of Clinical Excellence, which is a think tank in the UK, which collates all the trials and all the evidence and puts it together and sees what is there evidence for and what isn't there evidence for in terms of treatments. And it does this for medications and it does it for psychological treatments. It's entirely free. It's entirely impartial. If anyone can look it up, it's on www.nice.org.uk, and you can just download the evidence for any disorder and say what is there evidence for and what there isn't. Generally, you only see NICE in the papers when they have come out against a pharmaceutical company and said a pharmaceutical company's drug isn't quite as good as the pharmaceutical company says it is. And that's generally the only time that they come to prominence. But they're doing work all the time and doing work across general health, mental health, and all sorts of conditions. So this is specifically about psychological interventions, the NICE guidelines for PTSD. And so what it suggests is that a number of sufferers with PTSD may recover with limited or no interventions, that the anxiety does just go down over time, and that where the symptoms are mild, actually watchful waiting is the way to manage difficulties. We keep an eye on it. We don't have to rush to intervention. We don't have to rush to make an illness out of something that mightn't be an illness, and that actually watchful waiting is okay. For people who do experience PTSD over a longer period, all PTSD sufferers should be offered a course of trauma-focused psychological treatment. In this case, trauma-focused CBT, cognitive behavioural therapy, or eye movement desensitization and reprocessing. And so those are the two most evidence-based treatments for PTSD. These treatments should be normally provided by an individual on an individual outpatient basis. The duration of trauma-focused psychological treatment should normally be 8 to 12 sessions, where the PTSD results from a single event. When the trauma is discussed in the treatment session, longer sessions than usual are normal. For example, kind of 90 minutes, and treatment should be regular and continuous, normally about once a week. Health area professionals should consider extending treatment beyond 12 sessions if there are several problems that need to be addressed as well as the PTSD. So if there's multiple traumatic events or bereavement or chronic disability or other comorbid things like depression or substance use. For some PTSD sufferers, it may initially be very difficult and overwhelming to discuss the traumatic event. In these cases, healthcare professionals should consider devoting several sessions to establishing a trusting relationship and emotional stabilization before going on to do the trauma work. Non-trauma-focused interventions such as relaxation or non-directive therapy, which do not address the traumatic memories, should not be routinely offered to people who present with chronic PTSD. Okay. So what we want to talk about is, why does PTSD happen the way it does? How does it work? And in particular, we're going to focus on the trauma-focused CBT model in terms of getting better as one of the nice recommended guidelines. And so how does it work and how do we get better from it? I suppose are the two questions we're going to ask for more or less the rest of the talk. And so if we're thinking the core of PTSD is an ongoing feeling of threat. That's what PTSD is, this threat that keeps going and keeps going. And it comes out in three ways: through the intrusions, so things like nightmares, flashbacks, memories, avoidance of thinking about things, avoidance of going and doing things, and strong emotions, so anxiety, guilt, shame, depression. And so why is this ongoing? Why doesn't it go? And it's because at the top we have trauma memories that are faulty. We can also have beliefs about the trauma, that we believe we're to blame, that we did something wrong, belief that it's going to happen again, that if I'm not on total guard and I'm watching out for it, it's going to happen to me again. We get triggered again and again when we go into certain situations. Or we have dysfunctional behaviours. So the person who carries the knife around at night to keep themselves safe, the person who triple locks all the doors, the person who will only drive at 20 miles an hour to keep themselves from having an accident. Those sort of behaviours which on the one hand look like they keep the person safe, but may actually keep the person anxious. So this is a photo I took from an English newspaper, and it's a generic car accident. And we're going to particularly think of what it would have been like to be this person. And so if this person is driving down the road and has an accident, and the paramedics come and they're taken to hospital, what is their experience? And how are they then going to get over that and get past it? So if you're thinking of how this would fit with the model, is that the memory of that car crash is going to be incredibly jumbled. We can look at that and go, okay, well, this is what happened, and then that's what happened, and then A and B and C and D. But for the person, it's crash, bang, wallop, and it's all over. The memory is full of emotion, it's full of fear, it's full of noise, but it's not clear. And so how that's processed in the brain is going to be very disrupted. The person may have beliefs about that they hurt the passenger beside them, or that something, when they're actually in that moment, the beliefs they had in that moment is, I'm going to die, or the person beside me is going to die. We're not going to make it. Or then later they might have beliefs like it was my fault, or I did something wrong. They may have triggers like something like the smell of petrol or loud noise. And all of that feeds into an ongoing feeling of threat that comes out through nightmares, through not driving, through anxiety and guilt and shame. And that can, we run down a little bit, but that can lead into a lot of behaviours, like checking to see if the passenger, in this case John, is he okay? Is he checking him 10 times a day to see if he's okay? Watchfulness, going out of the house less, or trying not to think about it. And so we'd start treatment with a thing, just reclaiming our lives, reclaiming your life. And it starts with a small symbolic gesture of positive well-being. So something good and nice and positive that we used to do before the accident. We used to do before the event. And that would be putting our trainers back on for a walk. It may be going out for a coffee and a newspaper. And the idea here isn't to challenge anxiety. It's not to push ourselves. It's to do something kind for ourselves, to do something decent for ourselves. And if necessary, then also a period of anxiety management as preparation for the trauma work later on. But it's important that that isn't the only piece of work that gets done. And so if we were going to do the work on the trauma memory, what would we do? Trauma memories are different. They have a live, here and now quality to them. If you think, all the kids are off doing their Leaving Cert at the moment, and they're all hating it. And we can probably all remember doing our Leaving Cert and hating it too. But it's a memory. It's distant. We can't really place it. Although we know we hated it at the time, it doesn't have that gut level response for us now. That emotion has gone down over time. On the first day of our English exam, I'm sure we had sweaty palms and we were terrified of what was going to happen. But now, 20 and 30 years later, that emotion has gone down. Trauma memories aren't like that. The emotion is live. The emotion is the strongest part. The memory comes like a jumbled up jigsaw. It's not A and B and C. It's in a lot of different orders. And this is what leads it to be re-experienced. So if this is what happened from the outside, we can kind of see what might be here. A car runs into another car, then the paramedics come, then the ambulance comes, and then someone is taken to hospital, and that's the order things happen in. But for the person who's in it, their memory is going to be like this. It's going to be shards. It's going to be bits of glass. It's going to be the noise of sirens. It's going to be a face, but they can't quite put it in context. It's going to be huge emotion. There's going to be black spots in it, blank spots in it, where the person can't tell what happened then and what happened there. They know they were going into the roundabout and they can't place what happened after that. After that, the next thing they remember is the ambulance. And so that's the memory that people are struggling to process, and that's the one that gets reprocessed again and again over the years. So what do we need to do? The trauma memory needs to be elaborated. So as best as possible, help people to fill in the blank spots and then integrate it into context. So what order do things go in? What happened first? What happened second? What happened third? Why did A follow B? And why did B follow C? Because often when people don't know that, they fill it with their worst fears and they fill it with their own guilty beliefs. It was something I did, or it's something that's going to happen again. And when you do this properly, it reduces intrusive memories, flashbacks and nightmares. So the type of trauma narrative you might do for that memory we just saw is something along the lines of, I entered the roundabout going slowly. John was talking to me from the passenger seat. There was an extraordinary crash. There was a feeling of spinning. I didn't feel anything. I thought in that moment, I've killed John. It went dark. I don't know how long I was out. When I woke, a fireman was talking to me. I couldn't understand what he was saying. I kept gagging. I couldn't really speak. I was panicked. I kept trying to turn around to see if John was okay, but I was pinned in. Eventually, I was able to make out that they were saying, you are okay, you are okay. When they freed me, I was able to look for John. He had gone on in another ambulance. I didn't know whether he was alive or dead. I travelled in the next ambulance. Eventually, I arrived at the hospital. And so again, the person, not to change the memory, but to reprocess it in the order as best we can make out. And so this is what happened, and that's what happened, and that's what happened. And we're not saying anything positive. We're not trying to change any thoughts. We're not saying something positive where something negative happened. If John had died, then that's where we'd speak about that. But we're acknowledging what happened, and we're putting it in the right order. And we're allowing that person to reprocess that memory into context. So then we have a look at the beliefs about the trauma. And so typical beliefs might be, I'm going to be attacked again, or my life is over, I'll never recover, or it's my fault, I can never forgive myself. And what you try and do is see, well, actually, and it's amazing how many people, when they're attacked, believe they're the victim, or they're the one at fault. They don't see themselves as the victim, they see themselves as the one to blame. And so 100 people in the room mightn't see them as someone to blame, but they do. They feel it. They think it's their fault. And we start looking at alternatives. Is there any other way to see this? Is there any other way to think about it where maybe they weren't at fault? And looking at other points of view. And then integrating these into the narrative. And again, it's not about something positive. It's just about trying to bring in an alternative perspective that the other person mightn't have had when they were starting off. So the beliefs in this case might be I've killed John, or I'm not going to be able to breathe, or it's all my fault. Okay, it's a tiny bit hard to read for people. So what you would do then is bring it back into the narrative. I entered the roundabout going slowly. John was talking to me from the passenger seat. There was an extraordinary crash, a feeling of spinning. I didn't feel anything. I thought in that moment, I've killed John. I know now that it was the other driver's fault and that I drove safely and that John did not die. It went dark. I don't know how long I was out. I know now I was out for less than 5 minutes. When I woke, a fireman was talking to me. I couldn't understand what he was saying. I kept gagging. I know now it was the smell of petrol. I couldn't really speak. I was panicked. I thought in the moment that I was trapped and couldn't breathe. I know now that this was a mixture of anxiety and the smell of petrol. I kept trying to turn around to see if John was okay, but I was pinned in. This was because the steering wheel had shifted. Eventually, I was able to make out that they were saying, "You're okay, you're okay." When they freed me, I was able to look for John. He had gone on in another ambulance. At that time, I didn't know whether he was alive or dead. I know now that John was injured, but that he didn't die. I travelled in the next ambulance. Eventually, when I arrived in the hospital, I learned that although he had significant injuries, that he was alive. And so we're integrating the alternative beliefs back into the memory. So we're not trying to say everything is fine and you're doing grand, and here's the memory screaming that everything isn't grand. We're trying to integrate the other pieces in. And we're trying to make that as truthful as possible. There's no point having a false positivity. You're trying to bring in actually what happened, actually what went on, and integrate that into the memory. Other cognitive stuff you might do, other cognitive techniques you might do, is look for new information from ambulance crews or from other family members. Work out the logic of what happened when and try and work that out, because often everything happened in a spin. So the sense of logic is gone from it. Bring in a lot of self-compassion. And that on the level of beliefs, can I bring compassionate beliefs towards myself? But then in terms of imagery work, and maybe bring a compassionate image into the memory. Often we do anonymous surveys. So what do other people think? And then behavioural experiments. So testing out the belief. Does John blame me? For instance, what does John think about all of this? And then, if people want to, visiting the trauma site to see it again. And what happens when you do that is they find a really boring roundabout. And in their dreams, it's a nightmare. And in reality, it's just this junction with a couple of cars. And then when we're thinking about the dysfunctional behaviours, so people often get caught up in behaviours that make sense for them at the time and have a logic to them, but ultimately aren't helpful. And so I know someone who was assaulted, so they only shopped after midnight. And so they were actually putting themselves in riskier situations. They wouldn't go to Tesco at 12 in the day. They'd only go to Tesco at 12 o'clock at night, mostly because of crowds, but they didn't realise that. They were trying to keep themselves safe. And in doing that, were putting themselves in riskier situations. People try and suppress thoughts. But the more you try not to think about something, it has a boomerang effect. The more we try not to think of something, the more we think about it. And so when we try and push trauma memories out of our mind, what happens is they keep coming back. So for instance, I'd ask everyone not to think of a white bear. And instantly, it's the only thing that can come to people's minds. And if I'd ask you to really, really try not to think of a white bear, then it comes back more. And if we change that from being a white bear to something that was really personal to you, something really emotional to you. So like telling the kid before the leaving cert, don't think about the leaving cert. It's all they can think about. And so actually there's something about, let's bring it in and invite it in and hold it gently and compassionately and work through it. But what we can't do is push it out of the way, because it'll just keep popping up. Often people get caught between thought suppression, pushing it out, and rumination, dwelling on it all the time. And they get caught between these two extremes, that they can't think of anything else, but they don't want to think about it at all. And so they end up getting caught about maybe just one aspect and dwelling on it again and again and again and again. And they get caught in that loop. And then often people will get caught in safety behaviours, the idea of trying to keep themselves safe, but actually making themselves more anxious. And so going out with a knife, or staying indoors but having all the doors locked, or only walking on busy streets or quiet streets, or only driving at 20 miles an hour. So, for instance, if we were going to do an example of a safety behaviour in this room, if I took all the chairs and blocked the doors on every side, would you feel more anxious or less anxious? More anxious. Now, you'd technically maybe be safer from the danger, but your anxiety will have gone up because there's a presumption that there is a danger and that there's something outside the door that we have to keep at bay. And that's what we do in safety behaviours. We're keeping something at bay that mightn't be there, and in that respect, making ourselves more and more anxious. And so in the example that we're using, we might check on John's well-being 10 times a day. So people who've been in traumas often keep checking and rechecking how they're doing, how someone else is doing, how their loved ones are. They check on the kids 10 times a day, even though the kids are fine. Watchfulness, where we're scanning the room, or scanning the supermarket, or scanning the street for signs of danger. And then, of course, once we start looking, we're going to see it. We're going to see the dodgy guy. We're going to see the guy do the funny thing. We're not sure what that means, so we're going to get anxious about it. Maybe avoiding driving, or avoiding cars, or avoiding roads, or avoiding certain speeds. And then that mixture of thought suppression and rumination. The less we try and push it out, and then we end up thinking about it more. So what do we do? Well, we gradually ask people to start dropping avoidance. So we test out their ability to get back on the road, to get back in the car. We do this really slowly and really compassionately, and no one can ever do it wrong. And if it doesn't happen 1 week, it doesn't matter. And it doesn't happen 2 weeks, it doesn't matter. But that each step forward is a positive step. But we keep moving back towards what will be normal life. And what does anyone want in their life? They want to be able to go to work, they want to be able to drive a car, they want to be able to go on holidays, and all of those sort of things. The whole task of therapy is about reducing suppression. We start talking about the thing that can't be talked about. We start talking about the thing that the family don't want to hear about anymore because it's too upsetting for them. We start talking about the thing that the individual doesn't want to think about because it's upsetting for them. And very slowly and very compassionately starting to bring that out into the light. Because while that stays suppressed, it's always going to be reoccurring. And then outside of therapy, we're trying to get people to reduce the amount of time they end up thinking about it in their own mind. So you'll often notice someone who ruminates, they'll be at the dinner table and their mind will just have wandered. It'll just be gone off somewhere. And in the back of their head, they're just ticking over the thoughts again and again and again. Do people know the word rumination? It's what cows do with grass. They chew over it again and again and again. And then any sort of safety behaviours that might be going on, asking people to drop them. And then we do all the nice stuff. So that's all the tough parts of therapy. And that allows us to get to the really nice things, which is getting back to life, reclaiming our life too. Getting back to work, getting back to socialising, getting back to friends, getting back to shopping. And at that stage of therapy, every week is kind of quite fun because the person is back doing something again and getting a huge buzz out of it. I did this thing I haven't done in 5 years. Or I called up my friend that I haven't talked to in ages. And it's really nice. But one of the things that happens is that as they do it, a lot of the threat cognitions come up again. I went out to dinner with my friends, but I got really anxious in the restaurant because it was really busy. Or I couldn't get over the sense that really was my fault. And so you have to kind of go back maybe at that stage and just go over a little bit some of those cognitions again and think again about maybe why it wasn't the person's fault or what else may have caused this to happen. And then the last piece we do is about the triggers. So what's setting this off? And so in this example, we're thinking about reminders of traffic, maybe noise or speed or smell of petrol, something like that. So a trigger can be anything. It's generally a sensation of some kind. And what you need to do is to identify, what is it? What is it that sets people off? And so, is it noise? Is it taste? Is it light? Is it feeling, sensation, emotion, touch? And so, trying to work out what it is that's setting the memories off. They're re-triggering the memories. And at this stage, the memories shall have much less power and much less effect than they did in the beginning. But it doesn't mean the trigger doesn't still have some impact. And in this example, the crash with its loud noise and the smell of petrol is the thing that's been triggering for this person. And what you try and do is gradually differentiate the memory of that experience, what that crash sounded like in the memory. And they'll have a very felt sense of what that is from the sensation in the present. The loud noise, the bang of the cup, the slam of a door, whatever's happening in their everyday life now. So how is the smell different now? So if they're getting petrol in a garage, how is that smell different from how it would have been back when they were in the accident? And noticing, now I'm in an office and not in a car. Now I'm able to move around. Now I'm able to ground myself with pictures and to recognize I'm on a grey carpet, I'm at a grey podium, I'm in front of a load of terrifying people. And I'm wearing jeans and a jumper and not a shirt or whatever it is. And gradually being able to separate out how my memory of what triggered me is different from what's in front of me. It might be similar, but all the other things that are making it different. I'm at a garage, I'm at a pump, I'm at my car. It's an entirely different car because the old car was written off. You know, I'm going in, I'm going to buy myself a Mars bar and have a Coke and sit down and turn on Lyric and I'm in a better place. So how are we doing? Was that a lot of information? Or flagged out? Or very warm? There isn't a whole lot to go. Have we been going very quickly? Okay. And we'll be getting to the Q&A pretty quickly now. So there's maybe 4 or 5 slides left. But I realise it's a summer's day and only about 25% of the audience is asleep. So I think that's, I'll take that as a victory. So PTSD and depression are very common to see together. And in fact, we'd often see that the person gets referred for their depression. That, you know, John hasn't left the house and he hasn't been able to go to work and he's stuck in bed and all the, you know, classic stuff around depression. And then it's only when you go in and go peel back a couple of layers that you find that this has been happening. You know, there's been a steady slide since 5 years ago when he was in a traumatic accident and he's been having memories of that accident since that time and hasn't been able to get past it. And that he's using all the kind of depressive behaviours, the staying initially, where he's using the depressive behaviours, the staying indoors or the avoiding people, was initially to cope with the trauma and now has taken on a life of its own and has become its own depressive illness. And so often the depression is the referral difficulty and the trauma or the PTSD is only obvious after the assessment. And so if we've suffered a loss, we've lost a job or a limb or a change to ourselves, it's very understandable that somebody may also become depressed. The thing about PTSD is there has been a trauma. Something awful has happened. And so that often has left an impact on us. That we're experiencing long-term pain. We've lost something. Or we've been put in an awful situation. And so becoming depressed because of that, there's a lot of sense to that. That makes sense. I've lost something and I maybe haven't come to terms with what I've lost yet. And the depressed behaviour may also be understandable as a response to PTSD, to manage the PTSD. So I get flashbacks when I leave the house, so I don't leave the house. But of course, then ultimately, that becomes self-defeating and doesn't work. So what we have to do in terms of treatment is an integrated formulation. It's not either or, it's both. And so you want to work out, are the depression and the PTSD maintaining each other? And in what way, and how is that working? And then you wanted people to begin to understand both how depression works, and this will be a very knowledgeable audience about that, but also then how the PTSD fits into that and feeds off it, and how the two might feed each other. Every time I leave the house, I get overwhelmed and it's anxiety-provoking, so I come back into the house, but every time I come into the house, I get hopeless and my mood drops and I feel awful, and looking as a way of breaking through that. And what we want to do is to create enough wiggle room in the depression to do the PTSD work. And that's the key goal here. But what's useful is that many of the depressive thoughts that crop up in PTSD will also crop up in PTSD. So I'm useless, or I'll never get better, or I'll never get over this, or this is only me, or I'm the only person to experience this. That actually they're often in common. And so if we can address it in one, we can address it in both. And that if someone's PTSD begins to improve, so for instance we get the flashbacks to come down a little bit, then the person is freer to be able to get out of the house and do the things they want, and they're able to tackle the depression. And equally, as someone begins to overcome some of their PTSD symptoms, they can actually begin to value how strong that is to do that, how personally their recovery and their strength in order to manage this thing and overcome this thing is quite remarkable. And you can start to feed back into that low self and overcome that low self-esteem that happens in depression. And we can start to challenge that low self-esteem by the work the person is doing on their PTSD. So in terms of what that treatment might look like, that where we talked about reclaiming life, one, that first page about finding things that are small, symbolic, and powerful, that's a perfect place to start. You then might start to look at behavioural activation, because it has the best evidence base for depression, but you'd have to adapt it for PTSD symptoms. So you're not putting somebody in a hugely anxiety-provoking situation where everything's going to be re-triggered, and you're adapting it so that you can try and work around it a little bit. You're also going to try and reduce the room for rumination. So there's nothing worse than doing nothing for rumination. If any of us sit in our front room and just look at the wall, we're going to end up dwelling and we're going to end up worrying. So it is about trying to break into that a little bit. And if someone also has PTSD, then they're going to worry and think about the trauma. And so beginning to look at all those negative cognitions of myself and the helplessness and the hopelessness and put that in perspective. Where did this come from? And beginning to see that actually maybe this had a start, which was the trauma. And beginning to see that the logic of it and how then there's a logic out of it. And assessing risk and ability to manage the stress. And then integrating the trauma work that we've been talking about earlier. And then finishing it off with the really overcoming the depression. And I hope that kind of makes sense. I kind of rushed through it a little bit. Essentially what you're doing is you're taking classic cognitive therapy for depression, you're taking cognitive therapy for PTSD, and then you're ending it with cognitive therapy for depression again. And you're kind of book holding it. But you have to hold both pieces in mind. And that's what you're trying to do. Often, one of the issues that's going on is there's a court process or there's a HR process. And because something awful has happened, there's some legal aspect going on. And in general, this is just awful. They're just awful, awful, awful. They slow everything down. They're very difficult for people. They're not built with people's health in mind. They're not built with people's recovery in mind. They're not built with people in mind. They're built with laws and rules and regulations in mind. And it makes it much harder on everyone. And being 3 and 4 and 5 years in a court process has never done anyone's health any good, let alone PTSD and depression. It's just tricky, and there's no clear solution to this. Processes aren't generally designed with the person's best interest in mind. They generally slow or stop recovery. And all you can do is try to accommodate and support the person as best you can while they're going through it, realising there's always going to be a couple of setbacks. A solicitor's letter landed in my post today, and you're okay, we're going to be set back for a month now, right? Let's have a think about it again and let's work through it again and where we need to go from there. And just recognising how difficult that is. And then keeping the focus on recovery. Not the focus on winning the case or getting through the case or the HR process, because that's totally out of our control. But keeping the focus on recovery, because that's the only bit that is in our control. And it's the only bit that ultimately will make us happy or not happy. And this is the last slide. Just the recap, the core of PTSD is that ongoing feeling of threat. It's the intrusions, the hyperarousal and avoidance that causes. What we do in terms of work is to try and get the person to help them to reclaim their life, start to update their memory, start to look at alternative beliefs, then integrate that into the memory, keep a compassionate focus, and bring that compassionate imagery then into the memory, and then change any dysfunctional behaviours and tackle triggers. I do this work most days, or certainly a couple of times a week, and it is one of my great privileges to meet people and to work with people who experience it. And when you see the recoveries that people make, it is an extraordinary pleasure to be at the end point with somebody when you've heard the stories of what they've had to go through. And so on my behalf, I'd like to thank you. Thank you.